Daniel. How's it going?
Hey Evan, it's good. I feel like we haven't recorded in a little while. Excited to kick us off this morning with a fresh podcast. How are you doing?
I'm doing well. It's Friday, and we've had quasi decent weather in Portland and not a ton of rain this week, so that's been nice. Started with a new client 3 weeks ago, so absolutely like drowning right now and learning their processes, and then still helping out my old client from time to time. So that's been fun as well. So it's kind of nice. You're now on the bench for a while, so I'll be pulling you in on some of my client work to help us out for a bit. So
Yeah, first time on the bench in a little while. I think my thing I'm looking forward to most, I am picking up a piece of art on Facebook Marketplace later today. So that's my big news. I have a friend who's an artist who told me that's the best place to get art. So we'll see how it goes.
awesome. All right. Is it going in the office?
Yeah, it's gonna be
Something on the wall.
right above the computers. So
Oh, so we still won't see it.
no.
All right. Well, how are you recovering from your first bat with COVID and had to miss our company retreat?
Oh, it's I'm just glad I have a voice this morning. So well, we're doing okay. You want to introduce the topic for today, what we're talking about?
Yeah, so we're gonna talk a little bit about the big impact that's been happening in the nation recently, at least in healthcare, about around cybersecurity. We're gonna start off with that, and then we're really gonna dive into how patients, payers, and providers need to be coming a little bit together and hear about some cool stuff that's on the horizon that hopefully is gonna bring that together. And we got two leading experts in the industry as well. So, and I'm excited to have them on today.
Cool. Let's jump right in. I'm excited to talk about the patient stuff. I feel like we talk like revenue so much and don't really talk about the patient experience super often. But to introduce our first guest today, so back in 1999, they co-founded IPKO Telecom, Kosovo's leading telecom provider, and the IPKO Foundation. And they've been a digital health pioneer since 2001. Co-founder and CEO of the Commons Projects, Text for Baby, Voxava, and WellPass, and is the co-founder and CEO of Smart Health Network. Thanks for joining the show, Paul.
Great to be here.
Well, I'm excited to introduce our second guest, former vet. So thank you for your service in the United States Army. He's worked in various hospitals throughout the Chicago area. Really a background in leading nationwide consulting practices for across the country as well. He's currently the CRO. So for those listeners who are new to revenue cycle, because it's kind of becoming a newer term out there in the industry, which is the chief revenue cycle officer for the University of California, San Diego Health. Welcome, Mike.
Oh, thank you guys. Morning.
Great. Well, thanks everyone for joining. We're going to talk about, as Evan mentioned, cybersecurity. And I know that there's a lot of news, even maybe some as early as this morning. But Mike, I'm curious just how you're interpreting the recent news with cybersecurity and the impact on the revenue cycle and what goes through your mind when you think about it.
Thank you. Well, as we all know, revenue cycle is always looking for new challenges because our job is so easy and straightforward. No, but in all seriousness, the most recent attacks have really just been another layer of challenges that we've had to go through to the point where it's becoming more common. And the most recent one, unfortunately, is kind of a double hit, initial hit that happened at the end of February that kind of caused us to reel and spend increasingly more administrative burden and labor and hours to address and try to stand back up so we had cash coming in. So with that attack, and then the second one on the same area, unfortunately, that repeat, we've really had to start thinking about cybersecurity as being a part of our strategy. And kind of with any threat or risk, you want to have the education. You want to build as much prevention as you can. That I think has been in place for a little while. However, with this most recent endeavor that we've had to go through, we're really trying to rope it in to see how can we be better protected and kind of respond back. So we've taken these most recent events, as unfortunate as they are, and really try to turn it into how can we think more forward and plan for the next one or have some sort of redundancies and protection. So really change our focus a little bit instead of putting all our eggs in one basket, especially with a claims clearinghouse. How can we be better protected and siloed or maybe have those redundancies built in so that when an issue like this occurs, we've got the protection for the organization financially, but also our patients to make sure that we're taking care of them, we're educating them, and if there's an impact to them, that they're aware of what's happening and they have all the information in front of them.
Yeah, Mike, it's really interesting, right? How we saw kind of this even spike of as soon as it truly hit the media and patients started to understand it, we started to see customer service trends like a call center start to like escalate up. What are some of those strategies that you are putting into, your patient access, your self-service models and things of that nature to kind of like make sure that we have that quick sheet to do like patient education at the fingertips, because we never know when it's going to hit, right? Just like we could have a cybersecurity issue and we have to go completely down and darken into downtime mode. So what are some of those strategies that you and the patient access team and your front end teams are kind of strategizing and thinking through?
That's a great question. I think a little differently than maybe in years past is, at University of California, San Diego, we're fortunate to have some really strong teams, and one of them being our marketing communication team. Typically in my roles in past organizations, usually the executive team kind of meets and then we're telling the message to marketing or comm and trying to put it in a particular way. However, with the executive team we have here, they're a part of the discussion all the way through from beginning to end, and they're very engaged. So to your point, we've had a lot of talking points that were created and they were customized by team, so that each team had full visibility to all the talking points and all the FAQs. However, they were a little bit more specific, the call center, and letting them know just the general information, but also this, if you have insurance here or your insurance claim is going to go out, please don't worry because we will still handle it accordingly. On the back end, it's a little different because they'll say, well, I just had a service, so does that mean my claim is at risk? So the talking points for them were a little bit different. And then people walking in, to your point, if it happened that same morning, they're walking in and seeing it on their smartphone, making sure that they have that information very fresh so they can speak to that patient, educate them as much. I think the one difficulty with healthcare, and I'm not an expert in other industries, but I do know in healthcare, the level of understanding and awareness of the complexities of healthcare vary by patient. So you can have somebody come in, patient A, I'm not sure what's all this noise about the cyber attack in healthcare. And then the next patient is potentially an attorney who knows every single part of it. And maybe they dabble on the side in IT and they know a little bit of coding. And that question is, what exactly happened? What data points were breached? And what, am I at risk and PHI? And so we wanted to make sure we had our teams prepared with the right level of information. Going back to Daniel's point a little bit, education is part of our curriculum. However, this is just another layer that added a little bit more weight to our teams. So even though it was a claims or pharmacy issue that happened, it really is a burden that we all had to wear. Anybody that talked to our patients and our doctors, let's not forget them. Amazing people help to heal our community, but they need to keep their minds and their focus on the care that they're giving and the research that we're doing at University of California. But we also need to make them work, because you guys know as much as anybody, the patients might not ask the front desk. They're going to turn around and ask their doctors. So we wanted to make sure they had that information available to them, but also let's make sure they knew they can pivot to one of our teams that was a little bit closer to the details. So a big effort and almost the Marcom strategy in itself to make sure the education was flowing to all the right people and being as freshly updated as it could be.
I got to say, Mike, I think you're a little too generous in suggesting that there's anyone who actually understands the complexity of the healthcare system. Right? I mean, I get most patients don't, but I would argue that most people who spent their entire careers in healthcare don't understand the depth of the depths of the complexity. So
yeah, I'd agree on that.
Paul, on that note, what are you guys doing, from a business partner perspective? I can only imagine how much more heightened people are starting to ask and question as you start to approach and have conversations about, technology and that partnership component and how all of that data is kept safe, especially since we're such in a web and cloud-based area. Like, how are you seeing you're needing to pivot or even develop a different level of conversation as you're starting to probably get more intense questions is what we're guessing?
yeah, look, I think one of the key lessons from the last couple of weeks or whatever it's been has been a real recognition that we're talking about what's really critical national infrastructure. Right. I mean, I think people think about this, oh, this is technology, this is commercial, these are contracts or whatever. But, we've seen a big chunk of our healthcare system kind of, somewhat paralyzed. Right. So, I mean, I just think really at more macro level and almost sort of public policy level, I think there's a recognition that this isn't just some tech stuff or some some commercials and some contracts, but ultimately critical national infrastructure. So I think it really begs the question, how does the ecosystem as a whole start addressing some of these common problems and ensure that the kinds of sort of common utility services are built in a way that's sort of appropriate and structured appropriately and secure and robust to be able to serve as basically critical shared infrastructure.
I think I want to add on to that too, Paul. We're fortunate at UCSD that we have an amazing infrastructure team, most of that being our information technology and IT teams, and Dr. Christopher Longhurst, Josh Glandorf, and Scott Curry, our leading officers in that space, make sure that we, in terms of UCSD, are as protected as we can be, multiple layers of protection. That investment into the infrastructure that Paul's referring to, I guess my plea here, my 2 cents would be, and I used to be on the other side of the table, but when IT comes to the budgeting table and says, we need money to help reinforce, protect, enhance our security and our infrastructure, I think, I'm always looking for silver lining. These unfortunate events have nothing but supported and pushed that narrative forward because of the criticality of that infrastructure. It only takes one crack in the armor, if you will, to bring down a lot of that infrastructure. And of course, we do a great job protecting on that, but it's got to be an ever vigilant mission that we're on.
Well, and that's a pretty large, well-resourced, big institution like UC San Diego Health, right? There are a lot of, small practices, small organizations in healthcare that don't have those kinds of resources and yet rely on some of the, need to be similarly secure. So again, I think it really, for me, calls this question of, are there common utility services that actually create efficiencies for the whole ecosystem that can be built and secured robustly, even and leveraged by organizations that don't have the same capacity and resources and infrastructure that a leader like UC San Diego have.
Yeah, I think those are great points. I think I definitely see, especially critical access hospitals and even some of those rural health or even private physician practices, needing the same level of infrastructure and technology, but they don't have that financial means to do it. So, what are going to be those grants, or what are going to be like, here's the foundational component of being a provider that maybe, from a governmental perspective, they just issue like some of those protections and some of that technology base that's just core of like business for them. I know Daniel keeps trying to get off to ask something, so I'll be quiet for a second.
I was just gonna note, I mean, I think there's like a database from the Department of Health on like data breaches that happen. Anytime there's over 500 patient records or whatnot that are leaked, it gets out there. And like, unfortunately, data breaches and cybersecurity, like this isn't a new subject, but there's a couple of big ones that are on our radar that have us discussing it. And I guess maybe Mike, maybe more of a question for you, but do you see like health plans and other insurance providers out there like working with hospitals and like trying to assist in this like kind of critical time right now? Folks are struggling to get claims out the door. You're thinking about timely filing. I'm just curious, like what that conversation has looked like for you. Do you see them working with you, or is this something that they're like kind of taking advantage of at the moment?
That's a fantastic question, Daniel. This is for the first time where I've seen the majority of payer plans vet what's happening, maybe not immediately, but within a couple weeks, there was communication coming out and we were having our voices heard where they were extending timely filing considerations, authorization considerations, because this tool that was impacted with the tools definitely hit a lot of areas depending on how you were using these services and tools. I will say it's not at the level that is fully supportive, but for the first time, I did see the payer community and the plan community really come together and say, please don't worry about this, or here's the structure we're thinking about and putting in place. And I applaud that, because I know it's not easy to extend those allowances, especially when, as of 8:23 Pacific time right now, there isn't resolution to this issue that happened 6-7 weeks ago. So that has been a very welcomed gift that we did not expect. And I do think that in a positive way that is helping to bring the providers and the payers closer together. Now, that being said, there's still a couple big ones out there that we had to strong arm a little bit, or maybe they said it in a meeting, but I don't have it in writing. However, so far, we've been able to see those offerings and politely take advantage of them, given the situation that both of us, the plans, the payers, and the provider, were put in this situation. So that's very encouraging.
I think on the flip side of that, Mike, initially those first 2 weeks, you started hearing some of the responses from some of the payers of saying, "Hey, we'll do cash advances for the claims that we know are outstanding, that we're trying to process those payments through because we couldn't download the EOBs to match them with the 835s and 837s and go back and forth." But it had that contingency component of, oh, well, we're cash advancing it, but it's going to have an interest payment on it. And I think that's the part that put some health systems right at the stop of saying, even the smaller ones who needed those cash advances, to say, I'm not going to take the advance when I already know you owe me interest on other claims. So how is this going to offset? So, I was talking with a colleague and she was like, why would you owe me this money? Why would I take a cash advance on it with interest bearing? So, but immediately that conversation 2 weeks later, when they got hit and realized, oh, it's impacting them as well, because now they have to answer to security, that kind of went off the table, is what I was hearing. So what did you experience any of that? Did you guys, like, what was some of your strategy around there? I know San Diego's a little blessed because you do have 2 clearinghouses as well. So you weren't fully as largely impacted as some of the other institutions that I know have actually only have one, and it might have been the impacted one. So
yeah, the offering of the initial cash advance always kind of fit in that same bucket. When Daniel asked about, wow, this is an unexpected gift, this is great, we of course did our due diligence and read all the fine print. And when we saw that, 2 things: one, we immediately made a decision to pivot and say we are going to go to another clearinghouse. We had one that was already had some infrastructure built, so the pivot for us was easier than it would be if we had to start net new and had no agreements, contracts, paperwork. For the love of God, info security vetting. You don't want to immediately pivot to a partner without doing your due diligence on them as well. So luckily we had that in place. We're able to pivot quickly, and that's important because although this has been a massive administrative burden and labor increase to manually work the interim solutions, we were in a position where we pivoted quickly. So our cash, although impacted, was not nearly as impacted from a delay standpoint, nor was the aggregate of the cash truly delayed more than just a couple of weeks, because we were able to quickly pivot. So when I saw those offerings, the timing of those were coming through while we were already starting to send out claims and get our ERA set up going with our backup partner. So we decided to play conservative and not take any advances. And for a lot of reasons, one being the interest, 2 being we're not sure how this is going to look, how long this will need to go. And then 3, we wanted to make sure that if we were going to do it, we needed a real financial reason to do that. And luckily, because our plan was in place, the risk for cash for us was significantly less than maybe some others that were kind of sitting and pausing and waiting to see what happened after cyber attack, how long it would last. So we did not take any of those offerings, and I'm so happy that we did not do that, because we're already pivoting and standing back up very quickly. We don't have to deal with all those contingencies or paperwork or reconciling the cash with what was advanced and what we're collecting now. So very, very fortunate for the team and having that backup and the planning we did, how fast we did it. But we did not take advantage of those cash advancements, and I'm glad we didn't.
So last question before we run out to a break here. Paul, what are you thinking we're going to start to see from CMS and state legislation really coming out around these recent events?
Yeah, I mean, that's a good question. Again, I think I don't have sort of specific insight on, hey, we'll see this or that or the other thing, but I just, I do think you're just going to get, much more scrutiny on the kinds of services that really are common utilities and critical infrastructure, right? I think that there hasn't been a lot of scrutiny paid towards the kinds of digital services that are there's one thing with services and technologies that are within the span of control of one organization like a UCSD Health, but these sorts of kinds of services and infrastructure that connect much of the ecosystem, that's what I think of as really this sort of critical digital infrastructure. And I think you're gonna I think you're already, there are kind of hearings on the Hill and all sorts of things where people are starting to really look at, hey, how did the country kind of get into this position? And, what sorts of models need to be put in place so the kinds of services that a critical industry like healthcare relies on are, kind of built and operated in a robust, secure, and resilient way.
Awesome. Right. Well, let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
The No Surprises Act requires hospitals to provide a complete self-pay good faith estimate for all providers involved in the patient's procedure, even if the providers are not owned or managed by the health system. The challenge is how to efficiently request estimates from independent providers, how to hold everyone accountable for their contribution, and how to provide a complete good faith estimate within the 24 to 72 hour delivery requirement. At Collective Health, we believe the solution is an agnostic portal where providers collaborate and share estimates while having visibility and accountability to each other. The Hive GFE Exchange is the industry's only solution that brings together estimates from individual providers into one consolidated GFE. CMS may have delayed enforcement, but is your hospital prepared for a comprehensive GFE? Don't delay. Join the Collective. For more information, go to goodfaithestimate.com.
And we're back.
All right, so we're going to jump into the debate or hot industry trend conversation today. And I know we're going to be talking about smart health, and Paul, some of the work that you're doing there. Evan, you want to kick us off today just on this segment?
Yeah, I mean, as we were prepping for all of our listeners, we don't just hop on and start talking. We usually have a prep call to get everybody on the same page. But as we were talking, we were really talking about like this common thread of having to have more around patient transparency and patient provider and payer partnership, and really making this partnership. So, Mike, you were definitely kind of diving in and starting to share with us kind of where you are hoping and seeing the critical need of that partnership. Can you share with our listeners and a few of our viewers who might pop out to the YouTube channel, kind of like what's your perspective on this and on why is it becoming even more important now than maybe where it was in the past?
Yeah, thanks, Evan. I think the really important part of this is given the event we just talked about, cybersecurity, as well as solutions that really need to think more global in the way that it's approaching things. So I know that a lot of times and historically in revenue cycle, you do want the best partner, the best project, the best setup, platform, et cetera, to really nail it when it comes to a particular workflow, a protocol, a strategic initiative, what have you, to realize those KPIs or that immediate business need. I think the problem is if it does really, really great in that particular area, it usually falters or it can't expand past that. So you end up having a bunch of folks or a bunch of partners or connections to solve the overall revenue cycle or workflow need. At the end of the day, to the organization, it's a lot of maintenance, it's a lot of paperwork, it's also a lot of connectivity that you have to maintain and keep up with. And for, from a patient standpoint, you want to make it as simple and understanding as it can be. The last thing I'll say is for your staff, you want it to be simple too, because we're not trying to train them on 15 different softwares or or platforms to do the job and yet keep a smile in front of their face for the patient or for the doctor to keep their mind on medicine if they have to click all the way through. So a long way of saying we really think critically of the right partner, the right solution, and can it be a win-win-win when it comes to the three big parties, the provider, the patient, and our payer friends. So how do we do that? And that's really the mindset that we've really embodied and look forward to say, we need solutions that are, one, cyber secure, two, have a platform that can reach all three of those major parties, and then three, fix, obviously approach our business need. And is it really addressing the need that we have today? And through those kinds of lenses and reprioritizing, we've been in discussions with Smart Health and really, really excited and love the platform of what Smart Health is bringing to the healthcare industry.
Yeah, I think we've talked about this a lot on our podcast, Evan, that the CMS and what they're doing when it comes to things like price transparency and whatnot aren't always very patient focused. And Mike, to your point, it becomes a little bit on the health system to really focus on the patient and making sure that their experience is good. So if you're working with 15 different providers, platforms, whatnot, that can be overbearing to the patient. And Paul, I'm just curious, just like, what is the solution like Smart Health doing to support that patient focus, that patient experience, and thinking about, maybe if CMS isn't doing it, why are you coming into this space and trying to find a solution for that?
Well, first, we actually like to call them people, rather than not patients. Look, healthcare technology and the solutions that Mike was talking about are often developed and deployed within the scope of different organizations, right? UC San Diego Health, or a health plan, or even government programs, a Medicaid program, Medicare, CMS for Medicare. But we humans see different doctors and at different health systems, and we change insurance and we change jobs, and we see dentists and we go to labs and we sometimes go to urgent care. And all of those organizations or separate organizations, all trying sincerely to do the right thing and solve their problems, but they see us as individuals through their lens, right? For Mike, I'm a UCSD patient, right? But if I walked across the street to Sharp, they'd see me as a Sharp patient. But I'm actually one person, right? I'm the same person on this side of the street and that side of the street. And so a lot of health technology and a lot of health solutions have really been designed to, kind of to support the business needs of these organizations, be they providers, be they health plans, be they others. And we humans have sort of been, I hate to say it this way, but a bit of an afterthought, right? I mean, we've not been the primary stakeholder, and that's where the result is, how many portal logins do you have? How many health apps? It's funny, we gathered a big group of many of the industry's leaders last week in California at Health Evolution Summit, and we had a pretty extraordinary set of roundtable discussions with a lot of leaders in the healthcare industry. And the little exercise we did, the icebreaker exercise we did in our roundtables, was we made everybody around the table count how many apps and healthcare like portal logins do you have. The winner at my table had 27. She takes care of her mother, who has some kind of chronic issues. So she won the prize at my table, 27. And so really the approach we're taking at Smart Health Network is say, hey, what if you imagined a platform that was actually built for people, and by doing that actually made it easier to actually interact with the various organizations in healthcare that we as people need to interact with, and actually reduces the friction, makes it easier to sign into portals with a single password, makes it easy to share your profile and your coverage digitally without having to hand over a plastic insurance card that someone has to Xerox and type in, and actually takes away a lot of the friction that we encounter, and creates huge cost and operating expense for both health providers and health plans.
I know, Paul, what you were sharing with us about like pulling in all of the different types of documents and everything. I've sadly, I've had 2 family members this year, both in the hospital, and I'm like, they hand me their stack of bills, they hand me their stack of EOBs, and I'm like having to go line by line and like match these up. And then I'm like, okay, we need to call on this one. This wasn't billed correctly. This is a denial code, but you're in network and they're processing you as out of network. And yet the anesthesiologist, it happened at the hospital. So therefore you're in network because it was an emergency procedure. And like and if you don't know the industry to go through it, you kind of just like throw up your arms and then you just pay out all these bills and keep going. How like as you guys are developing this, and I know you've been working with, Mike at University of San Diego, you've been partnering with the rest of the UC system. I had the pleasure of being part of those conversations in the last year or so. How are you guys looking at flagging certain things or even putting an educational spin in the solution for the patient to understand how to leverage that? And then, Mike, on the flip side, how are you guys going to help educate the patients or the people, us individuals that are? I'm going to be a person who definitely is going to use this or make my family use it for sure. Like, how are we going to really educate that end consumer of that solution to be able to leverage it and understand it still? Because there's still going to be those components like not understanding like in network versus out of network unless you actually dive into it. But like, what is it saying and how is it going to do that matching of some of that stuff?
Well, look, I think the first thing is to start simple and, crawl before we walk, before we run, right? I think that let me just take a step back. As we've been obviously collaborating closely with UC San Diego and the other UCs and health plans like Cigna and others, many of whom we actually worked very closely with during COVID. And this sort of grew out of our collaboration during COVID when we managed to get most of the country to adopt a little standard QR code to put on vaccine cards. Instead of the paper CDC handwritten cards that most of us got to begin first at the beginning of COVID. And that actually really is what led to this, right? We managed to get most of the country to adopt that QR code during COVID. And then when that ended, we sort of said, hey, what's next? And what that really was the ability for an individual to carry with them a verifiable piece of health information. In that case, a record of, hey, I got 3 doses of Moderna on a QR code in my Apple Wallet. And as we were thinking about what next, we seized on this idea of insurance cards, where we all, many of us still have to carry our little plastic insurance cards in our wallets. I learned through discussions with Mike and other RevCycle people that it turns out the number one reason that claims get rejected are basically, kind of fat finger typing mistakes of, people mistyping those insurance cards. And it turns into a back and forth. And, even if it ends up getting paid, there's an awful lot of back and forth. And then we have some health plans that want to go digital. Like I have United, and United now has a nice little, digital United card I can download onto my my iPhone, which I refer to as a very nice piece of digital art because it's completely useless. Like I can't, they can't scan my phone, but that's why I still carry this because at least they can Xerox this, right? So that's kind of what led to this whole notion. We did our first sort of proof of concept last year with UC San Diego and Cigna, where Cigna put the QR code on the insurance card, walked up to a kiosk at UCSD, scanned it, boom, there was real-time coverage, co-pays, all that kind of information, kind of no typing required. And that, obviously started to build momentum into what is now Smart Health Network. We, though, like everything in healthcare, because it's always more complicated, we sort of learned that, like half of UCSD's patients have more than one insurance, like, your Medicare and your supplemental, whatever. And so we realized people couldn't walk up to the kiosk and, have scan 3 QR codes. And then, of course, at check-in, they also say, oh, who's your emergency contact and who's your preferred pharmacy and all that other kind of stuff. And so we started to rethink. And we also heard, I think, Mike, you guys have like 600 check-in points across the system, and that, hey, we're not going to put kiosks at 600, desks. So we kind of, went back to the drawing board and said, well, hey, how about you just put a QR code sticker on the desk and let the patient scan your QR code and check in that way. And so that's sort of how, kind of this all evolved. But I think, what it's turned into is, we're going to be provisioning smart health accounts for eventually everybody in America. We're starting in California, in Southern California. Which is basically just a profile, right? You kind of activate your account, you keep it for life, it's free, it doesn't, you don't lose it when you change jobs or employers or insurers or doctors. Basically it, when you check in, you can share your profile, and that can include your coverage information, that basic info that you otherwise have to, kind of fill in the clipboard. One of the other things we're adding, which gets to your question about your bill and EOB problem, is an inbox. Like, one of the ridiculous things about healthcare is, healthcare is the only industry on the planet that doesn't use email, because of course you can't send PHI through unencrypted channels like email. And so you either get like, oh, there's a secure message waiting in your secure inbox, of which I have 7, or, you get, realistically, I get most of my bills in the mail, and I get my EOBs in the mail. So, one of the things that we're doing is we're inviting organizations to sort of, to join the network and connect, is saying, hey, you can send messages of bills and EOBs into a consolidated inbox where people can at least look at them together. Now, eventually, Evan, I'd love the AI assistant that actually makes sense of my EOBs and bills and tells me what to pay. But we want to at least let them at least have one place to look at them both, next to, versus right now, like, I've got this thing in this secure pulled over here. I've got a EOB from United Healthcare, usually unopened on the table in my foyer. At least having one place to look at those things, we think is a good start.
Then the second part of that question, at least from the patient standpoint, the buy-in and engagement has been almost, I don't want to overuse the word, but it's been very easy, and most of it's been because of what Paul talked about, the QR code adoption. There's a lot of places in my neighborhood where I can't go to a bar or a restaurant. I'm not getting a menu, like, it's a QR code, or I have to go to their website.
Yeah.
Now that's a bit aggressive where they're kind of forcing the hand, but I get why they were doing it. So the adoption of the QR code technology, and then I think the part that's a little bit of a sell is, the profile part, but once again, not hard, because you really can't have an app or sign up to get anything unless you create some minimal demographics. So that's the 2 part. The third part of it is really, when we talk about the complexities, to Paul's point, that's really the education, which is not meant to be kind of the pitch for it, but the education is really kind of the pitch for it. It's, your insurance company has a lot of different information. You need to have that on you. And when I've talked with different patients, it's really, if it's a mother who's got a couple toddlers running around, and I'm asking you to pull out your wallet and all this stuff, that's a gimme right there. They already see the value. A busy executive is running around, or you're in a car trying to make an appointment between meetings or while you're running errands. So the education, the talking points is actually not very difficult. The part that we have to, that's a little bit of the sell on and the engagement is, guys, we have a 27 in Paul's example, 27 apps. This is the beginning of stopping that. This is really the beginning of having one that can be shared across, so you don't have to repeat your information. Any complexities or issues you've had with your claims or your bills, your EOBs, will be drastically reduced. I'm not going to commit to completely eliminate it, but from a clerical standpoint, a registration standpoint, it's going to mitigate so much of that. And then the last piece is, every organization is looking for access to care and increase that. This does that. It's almost one of the easiest points to make, is people talk about the complexity of how hard it is to get in. Well, scheduling, utilization, referral management, that's another discussion. But if I can tell you, once we lock that in, this platform makes it easier pretty much from scheduling on, which is the point of the platform. Then this really takes that first call or that first email or whatever platform they're using to get the schedule in, and it really takes their hand and holds it all the way through, which is really, really great. And it's something that we really haven't been able to offer. The last thing I'll say too is, we're talking about it from a patient standpoint. The other side of it is the employee standpoint. We're talking about a platform that'll take all this accurate information that's been vetted by the payers, because the information is coming from their system, and immediately get that into all the discrete fields in the EMR that then flow through to the claims processing and eventually that same payer with that information. So this is really a win-win-win, again, patient, employee, or provider. And then the plan is really looking, going, wow, this is 100% correct, or 99.9% correct of what we sent out. And so it really pushes it through. The one thing I'll say is, this platform is, Daniel, to your comment earlier, we always, the government, the provider, wherever it's coming from, we talk about transparency. I think patients and communities need to know I don't think anybody wants transparency more than the patients. Like that's 1A. 1B is the provider, because a lot of the narratives that providers get is a lot of times we're the bad guys, and we're not the bad guys. We're obviously there to heal the community, take care of the community and the needs. And this transparency really gives that very easy to understand information out there so that they can see that. So it's got to be transparency that makes sense. Otherwise, it's not really transparency. You're just giving me a clearer view of muddy water. It's like, great, I still don't understand what you're talking about. So transparency that makes sense.
Yeah.
And my normal kind of motto in healthcare ever since I joined it was, if it's simple and it's easy, it probably won't work in healthcare. This is one of the few rebuttals to that, because it is simple, it is easy, and it is working in all the pilots that we've worked through and the patient population we've been working with. So this kind of, even though I'm an advocate for it, it's rebutting my own common healthcare motto. So
We're so glad to be able to prove you wrong, Mike, you know? Yeah.
yeah.
So Mike, with that, like, I mean, knowing that you guys are an Epic platform, how is it when the QR code scanned? I mean, I know you have hundreds, if not multiple hundreds of payer plans built out and mapping of that. How's the system knowing, okay, here's the information and it links to this individual plan ID? Because at some point that has to still take place, right? And that's where I think, like, if I look at it, it's simple from an end user perspective, but from an technology perspective, it has to be very complex, because you're grabbing it, and at each organization they have different plan IDs, different plan numbers, and you being a host of a Connect client, even, and multiple Connect clients there at San Diego, I know you have multiple plans. You have your San Diego plans, and then you have your Connect client plans that are unique to them, and there's different mappings and different fields and everything. So how is that, like, what are those checks or triple checks? It's really taking away from the administrative burden of doing the typing, but it's kind of pivoting now your team to become the auditors of that information. Is that kind of what I'm gathering?
That's definitely a point. I know, Paul, you want to jump in on this, but I think your point, Evan, is the criticality and the attention to detail that you need to have from a system setup standpoint. So to your point, Epic or Cerner, to be honest with you, they both host mapping either internally or with partners for like RTE and some of those clearinghouses. It's an exercise in terms of mapping to level of detail that a lot of organizations might do their top 10 or 20, whatever that value they see is. That infrastructure, connectivity, those attention to details, it's not as complex with the tool as it might seem, but I will say that the investment and that pivot that you're talking about, Evan, to get that infrastructure more finalized in detail benefits in multiple ways, but especially with this platform, just because it keeps it all smooth and going forward. So that's something that University of California, San Diego, we have an amazing Epic team that we've done the mapping to a micro level, and the majority, if not all of our payers that make up about 95, 98% of our claims activity. So we've got a great infrastructure there. To your point, mapping that out does nothing but enhance both the employee, the claims denials, or at least lack thereof if you're doing it well for these kind of connectivity reasons, and also from the patient standpoint. But that's my 2 cents on that. I know Paul's got something to add as well.
Hey, look, I mean, first of all, it's still just want to say this is a work in progress. We're figuring it out, right? We're trying to solve a pretty complex set of problems, and they are very complex. I think, though, we're trying to ground this approach in a couple of basic principles. First, actually think of the human being as the central organizing point, right? Things get a lot simpler if you actually think about the person as the sort of center of this, and then start to solve those problems sort of what I think of as person up, rather than sort of institution down or institution by institution. If I go back to sort of, some of the fundamental unsolved problems, like we as people, patients, we're all frustrated by the, clipboards and why are you asking me for, the same information, right? So I think it's not hard to convince people of the sort of, oh my God, wouldn't you like to be able to like sign into all those portals with, with one password and not have to fill in clipboards? Like the consumer value prop is pretty clear. I think, there are obviously a lot of, huge efficiencies from a revenue cycle perspective and administrative perspective, frankly, both on provider side and on payers, right? So I think the challenge and the orchestration that we've been doing is how do you actually get all of those three parties and the many of those three parties actually say, you know what, let's actually solve this problem collectively rather than right now everyone trying to solve it, for themselves. So San Diego is doing the same kind of mapping, but so is UC Irvine, and so is UCLA, and so is Scripps. Everybody is trying to map every other payer, and everybody's basically trying to, do it all basically in isolation. So part of what we've done by creating this public benefit corporation structure and a governance model to say, look, we're bringing stakeholders together to build this to be a common utility. Let's try to solve some of these problems once and then not have to solve them every single time. And it starts with the person. I mean, the reality is in this country, we don't have a national patient ID. We have an MPI for providers. We don't have the same thing for patients. Most other countries, the government says, hey, here's your national patient ID, and everything gets radically more simple. I mean, can you imagine trying to make healthcare work without an MPI for providers? No one can wrap their heads around that, yet we do that for patients, right? I mean, just that's a cause of huge inefficiency. So by as individuals activate their smart health accounts, you effectively have an ID verified, resolved, identifier that then payers and plans can actually use to transact with each other. Because as we all know, every transaction in healthcare starts with fuzzy patient matching, right? Well, I think it's Mike. Do you think it's Mike? Yeah, we're 92% sure it's Mike. Let's call it Mike, basically, right? So just but wait a second. If we actually know that it's Mike has an ID verified smart health account with a sort of a resolved identity, and UC San Diego and Cigna both know they're talking about the same Mike, just that identity match can reduce friction in some of those sort of downstream transactions. So that's just one example, and one problem. There's another, as we sort of step back and thought about what are some of the other kind of unsolved problems. Consent management, right? There are, as we all know, all sorts of different reasons we're asked for consent in healthcare, right? Hey, HIPAA authorization, consent to treat, patient responsibility, research, all the forms that we fill out, but also, patient access requests, data sharing consents. Now there are many, CMS rules that are, either in effect or coming into effect, payer-to-payer API requirements, payer-to-provider API requirements, all, each of which have different sort of consent requirements. Some are opt-in, some are opt-out. But right now, every one of those consent processes is implemented in different ways by different organizations. Now, for us people, I don't know, do you remember what you've consented to in healthcare? What if you wanted to have a record? I mean, no record of that, obviously.
Yeah.
But just think about the challenge from the organizational side. I mean, just think about some of these multi-party consents, like payer-to-payer, right? It's a new consent requirement that CMS has mandated where, we as individuals ought to be able to say, hey, I'm moving from Cigna to Aetna. Hey, Cigna, I want you to share my claims history with Aetna, my new insurer. Well, what does that mean? It means both Cigna and Aetna have to agree that it's the same me. They both have to be satisfied that I've actually given a valid consent that they can both rely on. I mean, that's, and so either every payer he needs to figure that out with every other payer. And then, by the way, there are now a payer to provider API requirement. So providers are going to be able to say to insurance companies, hey, insurance company, tell me what I need to know from your historical claims about my patient. Again, that's, kind of, there's a consent requirement there. So that's another one of these problems that I don't know how you can possibly solve that problem other than doing it in a person-centered way. So, I share that because, there are, what we've been trying to do is we've been, collaborating with partners, like UCSD and Cigna and others, is we've been trying to sort of really abstract away, what are those essential problems that you just can't solve within the span of one healthcare organization, payer provider, and solve them in a person-centered common way. And so doing create massive operational efficiencies for everybody.
I like that immediately when you were talking about the individual kind of patient identifier and the solidifying that. Immediately what translated was Smart Health Network will be the blue check mark you get on social media like Twitter and X to make sure that you are the legitimate Mr. Paul Meyer and this really is him, because that does not exist. And another part of that is fraud and making sure that not, the well-intentioned patient, that's overwhelming majority, 99%, but every so often there's someone trying to manipulate the system. So that's another layer of protection to make sure that we are handling with that patient that is the same patient. It's being done the same way across the continuum. So yeah, it looks like Smart Health Network will be the blue verified check mark for social media and healthcare.
Awesome. Well, on that note, let's take a quick break and we'll be right back.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
Welcome to Advocacia, where we make enrollments easy. Our technology is built to superpower your team, providing a more consumer-friendly approach to enrollments into programs like Medicaid, charity care, and SDOH programs. Our tool integrates with your system to pull over data that auto-populates in the background, allows for screening for multiple programs, automated outreach campaigns, self-service tools, and e-signature and document capture. In the background, we're auto-populating forms, making your life easier. If you'd like to learn more, please reach out to Ben Bartholomew. Thank you.
And we're back.
All right, just wrapping up here in the last few minutes here. Paul, we'll start with you just on our Wilshire Lab question for today. What drove you to work in the healthcare industry?
Well, my mother was a longtime public health person, and so I sort of I'll blame her for and I started politics, I did technology, I built a telecom company, and thought cell phones were going to be a thing, and was thinking about what other things cell phones could be used for other than making phone calls. And she told me about this problem of disease surveillance with health workers and rural clinics and developing countries, need to report outbreaks of disease, and used to do it by filling in forms on pieces of paper. And we thought, hey, these cell phone things are going to be a thing, and maybe you can use cell phones. So I kind of blame her for my for the last 20 plus years in this, what I'll call, interesting industry.
Very fun. What about you, Mike?
My healthcare journey really started, I was younger, had a very serious traumatic health issue, a life event that it was a very, very serious life event. And while I was in the hospital, I got to speak to a person that I had no idea that in hospitals people existed that weren't nurses and doctors. Didn't know there was a business side to it, especially being younger. And the person that came to visit me every day, even on their days off, because they, I think, felt bad for my situation and being young and being near death. And I learned about what financial counselors and financial assistants, and I forgot his title at the time, but he really spent time with me and taught me that there's an entire business side to healthcare, which I had no idea existed. So through that relationship and that mentorship, I started thinking about healthcare in a different light, and that could potentially be an avenue for me. Fast forward to college, I joined the college, and my dad was an engineer, so I'm going to engineering college to learn electrical engineering. September 11th happened during my freshman year. That's when I joined the Army. And anybody who's served any time in the military will tell you the one thing that's common is we hurry up to wait. So you have a lot of time on your hands to think about life. And let's just say a lot of time spent thinking about life. I realized business and healthcare is where my heart is and where my passion is. So when I got discharged, I immediately changed my major in college, finished up with business administration. And the moment I graduated, I could not get into healthcare fast enough. And that's been the passion. That's my story. And that's the reason I love healthcare.
Awesome.
Oh. I was just going to wrap us up here, Evan, if that's all right.
Yeah, absolutely.
Well, thanks both for joining us today. We chatted about cybersecurity. We talked about smart health, putting the patient or the person first, and thinking about what that looks like for the future. I just want to make sure the listeners can connect with you if they want to reach out, have questions, or want to talk about smart health. Mike, what's the best way to have folks connect with you?
Thanks, Daniel. Email would probably be best. M as in Mike, A Vigo at ucsd.edu would be the best way to get in contact with me. And I'm more than happy to chat further on everything we've talked about or increase my network. So look forward to connecting.
What about you, Paul?
I mean, the best way is maybe on LinkedIn or at our website, smart.health.
All right, perfect. Well, that's it for us today. Thanks, listeners. Thanks, Mike and Paul, for joining us again. And if you have questions, submit them to the podcast. Talk to you later. Bye-bye.